On the 26th of December, 2006, a scientific journey to evaluate the knowledge base of HIV/AIDS outpatients began at the regional hospital in Koforidua, Ghana. The results of this pilot confirmed a piece of advice given by the ART regional coordinator, that a research study on drug adherence was necessary to establish the factors affecting adherence. Thus, study instruments for a research study on drug adherence to be conducted in the eastern region of Ghana were developed and pre-tested outside the study area in accordance with research ethics, at the Komfo Teaching Hospital in Kumasi, Ghana in June 2007. The main study began at the Eastern Regional Hospital in July 2007. There were difficulties in developing the research findings upon realizing there was no known model for computing the long-term adherence level of the ART respondents. Therefore, there was the need to develop a model to compute the adherence levels of respondents. The dose adherence model is the brainchild of this research study.
The scientific committee, fellow participants, sponsors, ladies and gentlemen, a presentation on the dose adherence model by the principal investigator, Ms. Torino Fosu.
Again, this model was developed to compute the long-term adherence levels of ART clients in the study area. I would like to reiterate the fact that this research study was based on previous work done, and I will duly acknowledge my scientific predecessors in the bibliography. Meanwhile, Chesney in 1997 defined adherence as taking 80% or more of the prescribed regimen. Bashile et al. 1998 further gave a range as, and I quote, reports of adherence range from 25 to 85%.
Adherence to antiretroviral therapy is essential to ensure that the ARV drugs are effective and to prevent the development of drug resistance.
Now, the literature review.
The list of the range given by Bashile et al. In 1997 is 25%, which represents the least level of adherence of clients who default continuously for weeks. The average of 50% given by Baisa et al. In 2003 represents clients who miss doses often, whereas clients who miss doses on occasion fell under the 80% category, suggested by Habrich et al. 1999. Patterson et al. 2000's least adherence level of 95% required for complete viral suppression and prevention of the occurrence of drug resistance is rounded up to 100% for clients who never missed their dose regimen since commencement of ART. There is no known model for computing long-term dose adherence of ART clients. Sample tweets on the next slide confirm this.
Please note that the tweets are constantly updated by date.
The significance of the model.
This model significantly aids clients in recollecting their long-term adherence as an addition to self-report.
And now, the study.
The study population for this research study was ART outpatients 18 years and above who were willing to participate on their refill appointment dates. Each respondent was sampled once. However, weak but willing clients and those below 18 years were not interviewed. Clients below 18 years normally do not make decisions concerning their regimen, and the weak ones might not complete the interview before their support persons interrupted the interview, thus their exclusion. The immediate stakeholders who consented to the commencement of the research are the regional, the district, and the hospital health administrations. The consent form was explained in detail to the clients who were willing to participate, and a copy of the endorsed form given to the respondents who wanted to take them. Most of the respondents would not take the forms home for fear of getting read by relatives who were not aware of their condition. The eastern region of Ghana was chosen because it has had the highest prevalence rate in the country since the first case of HIV/AIDS was discovered in the country in 1986, and the figures below confirm this. 15 of the then 17 districts, now 20, were covered. In all, 11 social support groups and 3 ART facilities. The study cut across a section of the population without bias in terms of education, occupation, religious affiliation, gender, and other social demographics, but was biased in terms of age. Standardized questionnaires were used in exit interviews to collect data. The next few slides discuss the salient questions asked to deduce adherence levels of respondents. The ART duration was used to compute the client's expected. The question on the frequency at 3 doses were made was psychologically aided. To enable respondents to answer the question on the number of times they have missed doses since commencement of ART truthfully, seasons such as religious seasons, traditional seasons, farming seasons, or fishing seasons, not forgetting national holidays or academic calendars, were used to aid respondents recollect their missed doses. The choice of alternative being synonymous with the occupational or educational background of the respondent. The computations are classified under the results and not methodology because they were products of the research and not a part of the planned methodology. The dose adherence model was developed from the expected doses, the default frequency, and the observed or actual doses. Since doses were taken twice daily at a 12-hour interval, the observed or actual doses were the product of the default frequency and the expected dose. At this juncture, ladies and gentlemen, I present to you the model for computing long-term. This mathematical model computes adherence as the ratio of the observed or actual doses and the expected doses. The observed dose is a product of the default frequency and the expected doses, with both expected doses at the numerator and denominator cancelling out, which otherwise stated the adherence level is directly proportional to the default frequency at a constant of 1. The adherence levels of respondents were statistically significant at a p-value of 0.0517. Over 80% of the respondents were 100% adherent, 14% were 80% adherent, about 2% were 50% adherent, and last but not the least, the remaining 1% were the least adherent at the 25% adherence level. I'd like to emphasize that pre-adherence counseling sessions reiterate the fact that ARVs are heavily subsidized, and any default on the part of the client will cause a removal of the subsidies, thus resulting in higher costs. Most clients have difficulty raising money to pay for the subsidized drugs. So in order to sustain the program, most ART clients in resource-limited settings adhere to the regimen religiously. In sum, this model complements other methods of determining short-term adherence and celebrates scientific literature by inculcating previous work done in determining long-term adherence levels of ART clients. I would like to recommend the use of digital devices built on the dose adherence model to aid ART clients in resource-limited settings to take their medications as scheduled. These are my literature sources.
Butchler et al., 1998. Chesney, M.A., 1997. Halbrick et al., 1999. Patterson et al., 2000. Weiser et al., 2003. Tweets on Drug Adherence, September, 2011. YouTube video, HIV Treatment Adherence is Essential, uploaded by Mindset Health, August 5, 2009.
The following people gave a helping hand along the way when I needed assistance the most. Mr. Peter Ejeba, for my academic supervisor. He is a research fellow of the Department of Community Healthcare University. He assisted with the development of a research proposal which won a grant of $1,000 from the Bill and Melinda Gates Foundation. He also provided guidance throughout the research from the pilot phase to the pre-testing stage to the main survey. Reverend Dr. Brown provided guidance on ethical issues and ensured the appropriate bodies and immediate stakeholders were involved. Mr. Joseph Mankwa was very instrumental at the administrative level, contacting the requisite health administrations to facilitate the research study. Dr. Gertrude Aquahagen provided insights on disease states and contributed her expertise in the development of the final draft for the acceptance by the School of Graduate Studies. Special thanks goes to Dr. S.B. Ofori, Regional ART Coordinator, upon his advice and field assistance. This project ran unhindered at the various districts. Lastly, I'd like to acknowledge Dr. Champon, also known as Archie of the HIV Clinic Comprehensive Teaching Hospital, for being my site collaborator at CAP. Without his input, the pilot would not have taken place.
Kindly visit these sites for further information on the model.
Look out for the digital tools for computing adherence at the next Frontiers of Retrovirology session in 2013. Thank you very much for your time.